Okay, so right, so there's a few questions from previous week and one new one today.
Yeah, so just
Right.
answer the top question maybe, and then go from question 7 down, and I just italicize them once you finish, or I will.
All right. Okay, so in an open bite malocclusion, how can the tongue's position be controlled to prevent it from protruding forward? Do you recommend including an attachment in the appliance design? So I think it's very important to diagnose whether the tongue is coming forward because there is insufficient AP depth or increased vertical. So if you're not considering that the tongue is resting in a forward position because it can't go any further back, then it's inappropriate to put in a tongue retraining component. So most open bites, skeletal open bites, and dental open bites are because there's something resting between the front teeth. Most dental open bites are related to thumb sucking or digit sucking or some adverse oral habit. And there's a tendency for that to naturally close up when the offending object is left out of the mouth. When the open bite is a skeletal open bite rather than a dental open bite, that's usually when the tongue is resting between the front teeth because there's insufficient sagittal depth and increased vertical height of the jaw structure, and the tongue cannot physically be comfortable in a retruded behind the incisor position because it effectively drives the posterior base or at the hyoid level to close up the airway. So in those circumstances, it's important to correct the skeletal open bite by modifying the growth to be closed forward rotation rather than an open backward rotation. Unfortunately, it's not an easy thing to close a skeletal open bite. You have to address it before usually the age of 10, and my only means of doing that is generally with orthotropics. But in non-orthotropic cases, we're attempting to close the open bite by DE extraction. So basically, we continue to keep the incisors in an open position, and at around 10 or 11, after we've done the transverse expansion and we intrude the 6-year-old molars and we extract the D's and E's into a closing rotation. So I briefly mentioned that in the 2-day introduction course, but it's an advanced technique that requires careful timing and planning. They're the only ways that I know. I don't use any form of tongue retraining attachments or extensions. Okay, next question. How often do we do cat wire activation? So cat wires are organically activated as you expand. So every time we see them, whatever your appointment interval is, 2, 3, or 4 weeks, whatever it is, we have to adjust the cat wires until the teeth are in even contact. So we readjust the cat wires on each visit so that the application of force is exactly what we want in against the posterior surfaces of the incisors. And as far as activation to make changes, say intrusive changes or tipping. Once the expansion is done, then usually I make a decision about what additional incisor movements, and every time they come in, I do a little adjustment, which is equivalent to about the thickness of the wire, so 0.9 mils, 1 mil, or sometimes even less, half a mil, depending on how sensitive the teeth are. So I'm adjusting cat wires every session actively, whether it's just to snug them up against the teeth as the cat wires expand in the expansion process, or again to make changes to the incisor position. I do that every time they come in. For deep bite cases, do you wait to start Gropex until you unlock the mandible? No. Deep bite patients, we usually start the exercises, within the first month of starting the expansion. One of the things that we tend to focus on is understanding that there's two basic exercises, the chewing at the dinner table exercise and the reading out loud exercise. The chewing at the dinner table exercise partially is to help with building muscle tone. The reading out exercise is to understand posture as it relates to punctuation. In deep bite cases, often they are reasonably strong in their muscle tone, so we might not focus on the chewing at the dinner table exercises, rather than instead focus on the counting and the reading out loud exercises. Once the bite unravels, then we can certainly start the chewing, and the upper development is quite rapid because it's 0.8 millimeters every 8 days. So within a month or two, the incisors are no longer as retroclined and start the chewing exercise. What metaphors or everyday examples have you found work best to help parents see this as a health investment, not just as a cosmetic service? Metaphors. The way I approach it is to share the treatment parameters that we look at in order to justify treatment. So treatment can be at any age in the child's growth and development. Right? Typically, orthodontic treatment is done at around 13 years of age, and that's done with the permanent dentition in mind, and that's done in order to streamline the treatment. At 13, we have lost the primary teeth as a general rule. We have all the 12-year-old molars and the 13-year-old canines in place, or as far out as they will likely come through if it's crowded. We have usually hit puberty, so we're entering the final growth and development process. So we know exactly how big the adult dentition is at that point in time, and we can very accurately estimate how much growth is remaining. So there's no real guesswork. It's quite straightforward in making decisions about how to align teeth, how much crowding there is, and what mechanics will be involved, and whether you're going to be able to do it as extraction case, non-extraction case, surgical case. There's, literally enough information to make a 5-minute treatment plan discussion. And that works for 80% of children who walk through the door, because 80% of kids today predominantly just have a dental malocclusion. Where it falls apart is for the 20% of the population that has a skeletal malocclusion, and if they have general health related issues that are associated with the jaw growth and development. In these cases, waiting until 13 means that you have ignored growth and health detrimental components for 10 years. So in those circumstances, we have different treatment timelines. If we're looking at health-related issues, we want to deal with them as soon as possible, right? So 5 and under makes a lot of sense for general health issues related to the jaws. If it's jaw growth imbalances, then we want to deal with it before 10 years of age, because we're still growing rapidly, we're plastic in jaw development. We can have a better chance of influencing the environment and influencing the posture to make growth and developmental course corrections. It's virtually impossible at 13 to make a jaw growth course correction, because we've hit puberty and our bones are hardening. So before the age of 10, if we turn up then, we assess for skeletal imbalances. We can do a angles classification evaluation, and we can assess for airway compromises in the nasal area, the nasal pharynx, the oral pharynx. So this is where we screen for sleep disorder breathing, because there's interlink between the jaw system and the nose, the adenoids and the tonsillar regions. So before 5, we want to screen for any of those issues, and then we refer accordingly to the appropriate sleep physicians or ENT. And then that is basically how we justify early intervention. We're treating different things at different timelines, and we're not necessarily involved in that treatment, but we certainly can be involved in the screening of that treatment if it's a health-related issue. And if it's a jaw growth imbalance, then we can screen before 5 and can screen before 10, and we can step in and we can make structural changes that will lessen the burden of the imbalance into the future. When do you take progress panos? What's the current orthodontic standard of care and progress x-rays? X-ray, the standard of care is you take an x-ray when you believe that it is needed to help you with your diagnosis. So when would we take an initial pano? Well, you'd want to take one at 7 to 8 years of age, where you screen for potential missing permanent dentition or impactions. And then you'd certainly want to have one before you're 11 to see if there's any issues with the canines being ectopic out of alignment to erupt through the pathway of the seeds. So what's the timeline? Well, we certainly don't need to retake x-rays within 24 or even a 36-month time frame for kids, but we are charged by most orthodontic societies as general dentists to do a screening with x-rays at around 7 or 8, and makes sense again to redo it around 10 to 11. again, to screen for potential ectopic permanent teeth or missing permanent teeth. Bridging the communication gap with parents. When parents come in curious but cautious, intrigued but unsure, how can we bridge the gap without sounding defensive or too scientific? What language helps open their worldview to see that postural orthodontics is part of whole child growth rather than alternative to orthodontics? So I think some of that would have been answered in the number 9 question about metaphors and stuff, right? So we're just trying to give parents an understanding of why we treat at the age that we treat and what we're treating. Right? So before 5, we are treating for medical health related issues that are intertwined with the jaw system. We as dentists don't treat airway disorder, but we as dentists can act as triage clinicians for sleep physicians and ENTs. And the time that is most critical for airway disorders is 5 and under, and it's one of the things that we can help in the general community health concepts of screening for airway disorders. So pediatric sleep questionnaire is one of the standard instruments that I use. Before 10, we are not looking so much at orthodontic imbalances, but we're looking for jaw growth, skeletal imbalances, and the easiest signs to help us determine that is the level of crowding or spacing and the occlusal relationship. So as dentists, we are looking at children's teeth all the time. And when we notice that the relationship of the bite is not ideal, if we look at the general relationship of the upper and lower jaw to each other and towards its requirement for fitting all the internal structures of the mouth, if it is outside of an acceptable range, then we want to investigate further. So what do we do when we're screening for issues as dentists? We look, we make a provisional diagnosis or a differential diagnosis. We then want to verify our diagnosis by organizing tests. What tests do? We might take photographs. Then we can look to see the level of imbalance, and then that might bring us to the next level of testing, which is radiographs. We might scan or take impressions for a Bolton's assessment analysis of the teeth size and teeth arch form shapes. With that information, we can come up with a definitive diagnosis of the skeletal pattern and the level of bite harmony and the level of crowding or spacing that's present. If we've run a pediatric sleep questionnaire assessment, we can make a provisional or differential diagnosis that can help our medical colleagues make a definitive diagnosis of whether there is sleep disorder, breathing issues, and if there's obstructive issues behind the oral structures or above the oral structures. That information then allows us to present a treatment plan, right? Or at least present a definitive diagnosis and discuss some treatment options to help manage the primary care issues that may be related to medical health, and to help manage the growth and skeletal growth pattern issues. And then we might talk about orthodontic considerations. How do we link it together so that it makes sense? The type of treatment that we are favoring is our understanding of how posture might affect the genetic growth and development of the jaw system, how adaptive postures in the mouth from potential airway obstructions or poor resting habits can create a disharmony in the matching of the jaws, because the adaptation of the skeletal pattern is very closely tied to whether we're resting with our teeth in contact and our tongue on the palate and the floor and the lips together at night. And as we do or don't, then the growth will take on a classic ideal forward rotation or a less than ideal backward rotation. And when that happens, if we are able to diagnose it early enough and change the resting posture, then we can make noticeable gains in improving the balance. So we need to address anything that we do with the same medical dental model that is used for any form of dentistry. Right? Patient comes in, you're doing a routine exam, you look in their mouth and you notice a shadow between two of the molars. And you say, there's a shadow. And they say, what shadow? And then what do? You say, well, have you noticed any food catching between that area? And they'll say yes or no, right? They'll say, oh, yes, sometimes I get a lot of food, especially when I'm eating meat. Okay? Well, that shadow, along with the slight opening of the gap, indicates there may be a breakdown in the enamel, right? So you've explained to them that there's a sign, which is what you've seen, and a symptom, what they've reported. Or they might say, no, nothing has changed since I last saw you. Then what do? How do you bring on the next step? So you say, let me take some photographs of that area so I can look more carefully under magnification. So you take your camera out, you take a picture, and you bring it up on the computer screen and you show them the shadow, right? You see, oh, this is part of the tooth. It's nice and white. You see that part of the tooth? It's nice and white. You see the bit in between? There's a brown discoloration underneath that margin, okay? And they say, oh, yes, I see that. Okay, what does that mean? Well, I'm not sure. Let's take an x-ray. I'm going to arrange to take a bite wing of that area. Are you okay with that? And they'll say, well, that makes sense, right? Because we want to investigate why there's a brown shadow. So you take the bite wing x-ray and what do you see? You see a demineralized area, all right? And you show them, you see this? This is all gray and black in color. And you see how the rest of the tooth is white and gray. Well, this is a breakdown of the enamels. It's a hole in your tooth. You say, oh, but I don't feel anything and nothing's catching in this. Well, it's an early stage breakdown. Right? Oh, what do we do with that? Can we just leave it and watch it? Well, if we do, then there's a good chance it will continue. Then you run your, I've done my diagnosis, right? What's the treatment plan? Well, we can leave it and wait and see. We can put fluoride in it. We can floss every day. We can do a filling, you make a judgment call based on your experience of how big that decay is. So how is that different to ortho? It's exactly the same. Oh, I've noticed there's some crowding at the front. Have you noticed that? All right. No, isn't that normal? I says, well, let's take some pictures. And we see, so you take some photos and then you show them. And you say, oh, look, there's crowding on those permanent incisors coming through. Well, we know that they're the final position. We know it's not going to get much wider than that. So we know it's not going to get better on its own. All right, let me just take, and then you talk about how much crowding you expect there to be in your estimation? And then they say, well, what does that mean? It says, well, it means that it's probably more crowded than is going to fix itself in the timeline ahead. Oh, well, what do we do about it? It says, well, we should investigate further to see the level of imbalance relative to what we would expect at that age. Would you like me to do that? And they'll say, yes. All right, we need x-rays, we need to scan for models, and we'll do an evaluation and assessment. And then you do an ortho exam. And then you come back after you've done your model analysis, your Ceph analysis, and you go through, this is a class 2, division 2 relationship. It's got crowding. We expect the canines not to fit, and the laterals to flare out. We expect the bottom jaw is retruded because of that A and B angle of 4.5 degrees, yada, 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 yada. Right? Oh, what can we do about it? Well, we can wait until they're 13. We can treat it now, try to reduce some of that imbalance. If that's how we do any type of dentistry. We treat ortho as dentistry and medicine, and we diagnose it the way we diagnose everything, and we present a treatment plan like we present everything in dentistry, and we offer options like we do in every part of dentistry. So it's a really important concept to remember that ortho is dentistry, and it's approached exactly as dentistry is approached. Right? It's not some random thing that is separate to the rest of what we do. Right? It is a specialty. It requires a lot of additional training, but its approach should be no different to any other part of dentistry. Which should be no different to any part of medicine, right? It has to be diagnosed in the same way. It has to be treatment planned in the same way. It has to be, you need to provide informed consent in the same way as medicine. What is the ideal E to E intermolar width prior to the 6s erupting? Generally, the 6s need to be around 38 millimeters, and the E width is generally about 3 mils less. So the intermolar width of the E's should be roughly 34, 35 degrees, 34 or 35 millimeters when the child is around 6 years of age. If you want everything to have a chance of fitting. You've often said to treat those who believe what we believe, but for those on the edge, parents or referring doctors who sense there's something more to growth guidance, what are the key bridge statements or principles that help us stay collegial while standing firm in our philosophy? I think how I've answered the previous questions applies. We have to help people understand the way we think. The way I think is that health is the single most important component of a child's journey in this component of what we do with them. Jaw balance is the next most important, and dental alignment is the next most important. And each of those things have a different approach and a different timeline. So if it's just permanent teeth alignment we're concerned with, then the teenage years is a fantastic time to treat. If we are interested in the health component, which is generally speaking sleep disorder, breathing issues that are intertwined with jaw growth and development, then as soon as possible, and ideally under the age of 5. And if it's jaw balance that we're interested in, then certainly if we leave it beyond 8 to 10 years of age, we're going to struggle to do anything other than accept whatever the Angles classification that they present with. If we want any hope of making changes to the growth and development, we have to change their resting posture, and their resting posture often is intertwined with any airway disorders that they have. So that component of dental alignment being intertwined with skeletal balance, being intertwined with the airway health, helps us understand that we don't, in our philosophy, just try to correct the end result imbalance of dental alignment, but we want to address the starting triggers for that end result alignment, which often is a distortion of the resting posture, which often is related to airway health. And then that impacts jaw growth and development because the posture is heavily tied with jaw balance. And if we address it early enough, we have a much better chance of making sure that the growth is in good balance. And that gives you a much better chance of the dentition aligning well, or at least having the space to be aligned well. So that's my philosophy. And when we express that ideology, then you will either attract people who find that train of thought sensible, or they might think, I don't think that applies to us at all. And it's just the response that they have to your particular philosophy, and that's my philosophy, and that's how I explain it. And they either find it resonates with them, and they'll say, okay, so how does this apply to my child? What can we do to find out? In which case you have a window to enter and continue on in the diagnostic journey. Or they'll look at you blankly and say, but does he have any holes? All right, well, can't we just deal with this later when he's a teenager? So yeah, of course we can. All right, or no, we have no holes, or yes, we have holes, and we have to get them filled. So that's, that's the concept that you need to be clear of, and then you can explain it after you have screened for pediatric sleep issues and taken orthodontic photographs so that you can share your view of that child's facial growth and development and the dental arrangement, alignment, and occlusion or malocclusion. We are a little bit overzealous into thinking that we have to verbalize and explain everything, and we underutilize record taking to share what we see. We train ourselves to see what the issue is, but they haven't been trained to see it. So we have to take records, and the least invasive of those records is a medical questionnaire, followed by extraoral and intraoral photography. Luckily, just those two instruments alone are enough to share with parents the growth and developmental journey that their child is currently undergoing. Right? It's easy to see if there's an imbalance. It's easy to see if there's crowding or spacing. It's easy to be revealed if there's a medical health issue just with photographs and a question. That's enough to bring to light the issues that you see if you're interested in early intervention. And that's enough for the parents to make a decision if they want to investigate further or not. And then you have the beginning of a journey of taking that family into your care and illuminating through proper orthodontic diagnosis and treatment planning of the treatment options that you would favor for their child.
So, Simon, can you just answer one quick question that was from an attendee, Dr. K, up the top? I put it up the top. Thank you. Is this one last question, if you've got time? Question 2.
All right, so last question. In your 2-day introduction program, you shared a picture of Usain Bolt and his great toe. What was related? Was that related to fascia attachments? Just let us know. Fascia, I'm not sure how that may or may not be related to fascia attachments, but this is a man who wears, when he was training, would wear his trainers, his foot wear for, I'm assuming, the majority of the day. And over time, his foot recontoured itself to fit the shape of his shoes. Most of us will wedge our feet into a pair of shoes. They don't quite fit, but the shoes break down and reshape themselves over time to our feet. With these professional athletes, their shoes are basically brand new. They put them on, and before they had even remotely worn out, they replace them with another brand new pair. And what happens is if the foot doesn't match the shoe, then instead of the shoe breaking down to match the foot reforms to match the shoe, because the shape of the shoes don't change because they find a pair of shoes that the sponsor wants them to wear, and then they just get 100 boxes of these shoes, and every couple of days they throw the pair out, put a brand new one on. So the shape is constantly the same, and their foot has to adapt to whatever the shape of the shoe is. And if you have a look at shoes, very rarely do they look like feet. They have a shape that's looks like a shoe. Feet eventually become the shape of that shoe. All right, that's our exciting adventure for today done.
Okay, thanks, Simon. All right, I'll let you go. Get back to work. All right. So, folks, sorry for the late start. We'll be, as I said, here generally every week. There'll be times when Simon has some emergency at work. This is his lunch break. So as we having some new students coming on board, this weekend we have a weekly schedule now. It used to be bi-monthly, but we'll be running these Q&A sessions to support the students who've just joined our 2-day program and anyone who's enrolled in our advanced training. For those of you who are joining this weekend, if you've got any questions, feel free to type your questions in the chat. For those of you who aren't aware, or this weekend we have our 2-day introduction. Normally we do it once a year, and this is the first year we've done it a second time. So we held one in June, and so this will be we've done 7 over the last 6 years. So this will be our last event this year, obviously. 2-day program, November 7th and 8th. If we've got some really good specials still for anyone last minute wanting to join. It's only 197 for the live stream. If you want the recordings, there's an extra 200. So we're going to close off registration tomorrow. Anyone like to join? If you're from other non-US based countries and you want to inquire about some specials, send us an email, info@straight teeth naturally. But hopefully we'll see you this weekend. It's going to be Friday, Saturday, if you're based in the US. New York time, it's 2:30 registration, 3 p.m. to 10 p.m. Asia will be very early in the morning, Saturday. Apologies. But the recordings will be available, with generally within about a week of the event after we clean things up and whatnot. But that's about it. So yeah, every week we'll be on with Q&A to support the students who've joined our 2-day program or advanced training. Get your questions ready. You can submit them in advance. As you're going through the recordings, or as you're going through the program, write down your questions. You can, if you're part of the implementation vault and get the Q&A support package, which is an optional extra. Some of you just want to attend the live stream. Some of you just want the recordings. But if you want to get the Q&A support to ask questions, write those questions up and prepare them, and you can ask them inside our private Facebook group. So if you have the implementation package, Q&A support package, you can tag my brother in the Facebook group with questions as well. So anyway, we'll look forward to seeing those of you who've joined us this weekend. Any quick final questions before we put our final preparations for this weekend's event, which should be fun? Got some guest speakers, Dr. Kevin Boyd joining on day 2. The agenda, we've emailed everyone. So on that note, we'll see you next week or this weekend if you're joining our 2-day program. All right, cheers. Thanks so much. We have recorded this. We record these Q&A sessions, and we upload them onto our YouTube channel every week, generally a day after. And if you're not familiar with our YouTube channel, it is the handle is at Dr. Wong Simon. Let me just give you the link here. Here we go. All right. That's the YouTube channel. Down the bottom there's a section, Q&A, weekly Q&A webinars. That's where we upload the webinar if you joined us a little bit late. Terrific. All right. Thanks everyone. Take care. We'll see you next time.